Okay, so recent elections aside, we'll move on. And actually, I want to change gear to the patients who are not candidates for bevacizumab, and that would be squamous cell carcinoma. And Corey, we'll have you address this initially. What good performance status patient, 60 years old, squamous cell carcinoma, no major comorbidities. In 2013, what is the frontline therapy for this patient?
So there are two basic options, platinum combined with either gemcitabine or taxane. I think you can't go wrong with either one. Not sure you can go all that right because let's face it, the response rates still are only about 25 to 35%. Progression-free survival is seldom better than 4 to 6 months. And increasingly, certainly in the last 5 to 7 years, we have a number of trials that show that squamous cell patients, regardless of the regimen that's used, seem to have inferior survival compared to adenocarcinoma. Pemetrexed and bevacizumab are not options in these patients. The bulk of maintenance data that exists has generally been positive primarily in a non-squamous population. The molecular markers we have discussed at length, by and large, do not usually apply to this population. So to some extent, squamous is really a major unmet need. There are recent data Mark's helped spearheaded looking at nanoparticle-bound paclitaxel or Abraxane that would suggest perhaps that drug might have a preferential advantage.
It showed a higher response rate in the squamous population, actually quite impressively, 25% for carbo-solvent-based paclitaxel versus 41% for carbo-nab paclitaxel. And this was by independent radiologic review. Absolutely no difference in response rate in the non-squamous. That was the primary endpoint. Obviously, we didn't anticipate that going into the trial. We did not power the squamous population to look at survival endpoints. There was, I guess if you're an optimist, and many oncologists are, there was maybe a trend in the squamous compared to the general population, but it wasn't powered. At the end of the day, it was not statistically different with regard to PFS or overall survival between solvent-based and nab paclitaxel. So it did, based upon the response rate, gain FDA approval as an indication for this. It remains to be seen, how this will be interpreted nationwide at the community level. I do think there's obviously a role in selected patients, patients who can't or aren't optimal for steroid prophylaxis, those sorts of things, or have hypersensitivity reactions to solvent-based paclitaxel. It may be preferred in that squamous patient that you have the sense after, typically we see patients for 2 or 3 visits before we give treatment because we're staging and doing other things. And you get the sense that their symptoms are rapidly progressing. This response rate was pretty impressive, so I think that would be an area to think about nab paclitaxel in that setting.
I also think in the squamous cell carcinoma population, I tend to do more maintenance in these patients. So I go by the Saturn data with the platinum taxane, usually cystosataxol, followed by erlotinib maintenance. Largely because these patients, I think once you can control their disease, there's a small window of opportunity before you can't.
I find, unfortunately, that the majority of my squamous cell patients never seem to make it to maintenance. Their disease is often progressing by 4 to 6 cycles, and to be frank, we're dealing with second-line treatment at that point.
So I think all of our panel would agree with Corey's initial comment that squamous cell lung cancer is the major area of unmet need right now in terms of new drug development. And luckily, the recent publications, such as that of Dr. Hammerman and his group, showed that we have lots of targets. Around 75% of the cancers that they did next-generation sequencing on had potentially actionable abnormalities.
Yeah. It was provided some degree of optimism that we might have some therapies that would be more effective.
And all we have to do is find those therapies.
Well, but we need proof of concept that you can identify that and alter the target for a clinical benefit.
To identify your analogy, we got a lot of people on the bus, and now the question is who's driving the bus?
That's a good point.
Or how many people are driving?